Okay, we're going to start the panel now, and before we do that, I'd like to introduce a few people to you. This panel is called Opioids, Treating an Illness, Ending a War, and it's an apt name because it's a recent report that just came out, and the lead author is here with us today. For those of you in the room, I'm sure Sentencing Project is that entity that's been out there for so long, reminding us with data and evidence and stories about this issue about drugs, mass incarceration, and the like. Their go-to for resources when you're looking at what can we do, what are the areas that we need to address. And we brought Mark Maurer, the head of the Sentencing Project, here a few years back to talk about drug policy, and we're lucky to have the lead author of this recent report, Nazgol Ghandnoosh, here today to not only give a brief presentation on the report, but also to moderate the panel. I'll note, it's kind of sometimes it's funny how life is very serendipitous, and I'm on my way to Mass this morning, and I turn on the radio, and the first thing I hear is about White House opioid summit that's happening right now, today. I hadn't heard anything about that. I looked to see if it was on the White House. I couldn't find anything, but NPR just happened to be doing a story about it. And the idea of it is they were interviewing the Surgeon General, the new Surgeon General, relatively new, who's actually experienced his brother being in and out of incarceration, dealing with addiction, and he was talking about that issue. And looking to what states can do to address this. And we luckily have with us here today some real warriors, the people that have been in the front lines of doing this type of work, of treating drug issues as a public health issue, and as voices in the wilderness for a long time, and we collectively have them here today. We have Dr. Emily Wang of Yale and the Transitions Clinic. The Transitions Clinic is a leader in this field and folks reentering the criminal justice system and addressing their public health needs. They have partnered with Colleen Gallagher and Dr. Maurer in DOC in the public health, making the argument that straight detox is not a way to deal with a lot of folks that can be treated through maintenance of medications that assist with addiction issues, and to treat this issue in a harm reduction approach rather than an abstinence only. We also have Amitha Smith, who's one of the outreach workers for transitions and has her own story to tell. And we have Daryl McGraw as well, who has a personal story to tell, but also is now, luckily for us, at Demas with their outreach programs on addiction. And last but not least, Lorenzo Jones, who was a policy advocate way back when, when Bill and I were trying to get some of these laws changed, the crack powder law that I believe it was Governor Rell finally signed, really pushing people to try to get to see the disparity there. And it was just fascinating and really frustrating that people weren't willing to take that stand without a lot of pushing. And now Lorenzo, he's traveled afar and, cut his teeth with Robert Rooks and others elsewhere, and is back in Connecticut now to lead the Catal efforts here in Connecticut, and we're happy to have him. So he's going to be talking about some of his work in particular. So without further ado, because I know I cut into it with my fiddling around here in the morning, we're going to bring up Nazgol, and we'll start this panel.
Thank you so much, Andrew. Hi, everyone. It's a pleasure to be here. I have a list of types of people that I usually don't like to speak after because they're just sort of daunting speakers. So my list has included preachers, politicians, and now I'm going to add presidents of Black student associations to that list. That was an amazing speech. Exactly. Okay, so I am a researcher at the Sentencing Project. We're a DC-based criminal justice research and advocacy organization. We've been around for over 30 years. And much of the work that we do is focused on trying to reduce the prison population in the United States. I'm just going to time myself here so I don't go too far. And to address racial disparities in the criminal justice system. And so with this report that I co-authored, we present our input on why we shouldn't scale back up the drug war to address the opioid crisis, and try to present some solutions of which policy responses would be appropriate in order to address this crisis. And I'll go over that with you today, and also reflect on the previous and ongoing war on drugs and its impact, and how that should inform our response to the opioid crisis and vice versa. So I'm going to start with showing you just the overall trends in overdose deaths. This is opioid overdose deaths in the United States from 1999 to 2015. By 2016, 64,000 people died of a drug overdose death in the United States, and generally in recent years, about 2/3 of drug overdose deaths resulted from opioids. The CDC has explained, and you can see from this chart, the top blue line shows the number of overdose deaths from the rate of overdose deaths from commonly prescribed opioids. And so that has really very much followed the dramatic increase in opioid prescribing in the United States. And so that's a major factor driving the opioid crisis. Next comes, in recent years, you can see a great uptick in heroin and fentanyl and other synthetic opioid overdose deaths. And that's been an issue driving these fatalities in recent years. Another way to look at this issue is by the race and ethnicity of the population that's dying from drug overdose deaths. And so this is showing you specifically the race and ethnicity of people dying from opioid overdoses. And what you can see is that this is a rate per 100,000 of the particular population that's shown. So this is a crisis that disproportionately affects white Americans. The rate of overdose deaths from opioids have increased across the board for everybody, but it's particularly impacted whites. It's also impacted American Indians, so that's received less attention. But it has had less of an impact, relatively speaking, on African Americans and Latinos. Part of the explanation for that is the ongoing bias and inequality that we live with in our society. So because white Americans have had more access to health care coverage, they've been able to receive opioid treatment to address the pain that they've presented to doctors. They've had access to health care in order to be able to access those opioids. In addition, researchers have shown that when African American patients present themselves with pain to doctors, they're less likely to receive treatment and to receive opioids compared to whites. So those things combined have shut the door in some ways to pain treatment for African Americans and contributed to their lower overdose deaths, relatively speaking. So this portrait here of who is affected and who we think is affected by the opioid crisis has contributed to a very different response to this drug crisis compared to past ones. So, for example, if you think back to the last presidential election, there's a lot to remember. But one thing that stands out that's relevant for our discussion today is that many of even the Republican candidates would talk about their personal connection to overdose and to substance abuse problems. So Donald Trump talked about his brother who died, who was an alcoholic. Many of the other candidates talked about deaths in their family or struggles dealing with drug use and alcoholism as well. That's very different, as Michelle Alexander pointed out yesterday, from previous drug crises, like the heroin crisis of the 1960s and the crack crisis of the 80s and 90s, where these drugs were, drug use of these types were seen as a moral failing of individuals rather than a chronic illness that deserved a public health response. So what have been the responses to the opioid crisis? So here's what's happened at the federal level. At the top here, I have listed a couple of the responses that occurred during the Obama administration. And so Congress passed the Comprehensive Addiction and Recovery Act in that period, which modestly increased investments in prevention and recovery and treatment programs, increased access to naloxone, which is a drug that reverses an opioid overdose. The Surgeon General urged physicians to follow CDC prescribing guidelines and limit the use of opioids for chronic illness, and instead focus on prescribing opioids more for acute pain. And there, of course, the signature achievement under the Obama administration, the Affordable Care Act, increased access to care, access to mental illness treatment, and to drug treatment as well for people who are able to, who live in states that expanded Medicaid. Under the Trump administration, there has been some talk about these issues, but less action. So Trump declared a public health emergency, which in terms of the options of kinds of emergencies he could have declared, this did not open up a lot of funding to address the crisis. He created a commission to study the opioid crisis. One of the commission members, former Representative Patrick Kennedy, later and ongoing has been describing that process as a sham because none of the commission's recommendations have been taken seriously and have been followed and pursued by the administration. And he's also, Trump and Attorney General Sessions have been focused on reversing the reform efforts that occurred under the Obama administration to scale back extreme sentences for drug offenses. So that included scaling back a policy that Eric Holder implemented to reduce charging among federal prosecutors. And so the idea, here is that, especially when it comes to heroin and fentanyl, the federal government wants to be very tough and try to discourage drug use by tackling supply. There's one more point about Trump administration's response. He has said, quote, that he promises to do really tough, really big, really great advertising in response to the opioid crisis, even though that we know from past drug crises that advertising actually to discourage people from drug use can sometimes be counterproductive. So what's happened at the state level, there's been a mix, actually, of efforts to provide and increase access to treatment and to prevent substance abuse disorder, and there's been punitive responses as well. So a number of states have increased access to naloxone, the drug that reverses opioid overdoses, have limited opioid prescribing, discouraged doctors to prescribe large amounts or long duration for a long period of time. And they've also expanded treatment accessibility by requiring insurers to provide coverage for drug treatment programs, and New Jersey's really been a leader here. In terms of punitive responses, there have been many measures around the country to increase penalties, prison sentences for, in particular, selling heroin and fentanyl. And there have also been measures around the country to charge sellers with homicide if the drug that they sell results in an overdose. And Connecticut, unfortunately, gets on the map here with proposals, two proposals introduced last year to introduce drug-induced homicide laws into the system here. So given this interest in ramping up the drug war in response to the opioid crisis, I want to go back and reflect on what we've learned from the drug war so far. This is a quote from the National Research Council. This was a body that put together a group of leading scholars to look at criminal justice policies and their impact. And what these scholars concluded was that for the past 3 decades, the successive iterations of the drug war were unlikely to have markedly or clearly reduced drug crimes. So that's a really devastating evaluation of the war on drugs, given what it's meant in terms of the cost for our society, in terms of the cost for communities that are having a lot of people go into the criminal justice system for drug use and drug sales. So just to give you a sense of the scale, in 1980, 24,000 people were incarcerated in U.S. prisons, state and federal prisons, for a drug offense. So 24,000 people in 1980. When this population hit its peak in 2007, there were 369,000 people in US prisons serving time for a drug offense. Over 2/3 of that population was African American or Latino, even though drug use is similar regardless of race or ethnicity across the country. Surveys routinely show that Americans use and use drugs at similar rates and generally purchase drugs from people of the same race and ethnicity as them. So because of the growing realization of the inefficacy of the drug war, the injustice of it, and the destructive aspects, the impact that has had on communities, in particular communities of color, there's been progress in recent years to reduce the number of people that are imprisoned for a drug offense, to reduce arrests, reduce the number of people admitted into jails for a drug offense. And so here I show you just the numbers at the prison population level, so people serving sentences of generally of 1 year or longer. So the chart on the left shows you the number of people serving time in state prisons for a drug offense increased from 19,000 to 270,000 in 2007, and then decreased by 25% since then. The similar, much more dramatic increase in the federal prison population serving time for a drug offense, and again, a similar reduction in that system as well. Though, as you can see here, the federal prison population is much smaller than the aggregate of the number of people serving time in state prisons for a drug offense. So this has been really incredible progress. I want to point out, though, here that in terms of the broader goal of ending mass incarceration, reducing drug admissions and drug sentences is not quite going to be enough to achieve that goal, because while there's been a 25% reduction in the number of people serving a sentence for a drug offense, the overall prison population in the United States has only declined in size by 6%. That's because most people, especially in state prisons, are there for other crimes, for violent crimes such as assault, robbery, and more serious crimes. And so in terms of thinking about where this fits into the broader goal of ending mass incarceration, we clearly have a lot more work to do to end the drug war, but we also need to think about taking the next step to reduce sentences for other offenses as well. And I just want to highlight Connecticut here is actually a national leader in decarceration, thanks to the effort of many of the people in this room. So the Connecticut prison population has declined in size by 28% in the last decade or so. So our recommendations on how to proceed, I have them summarized here, but I'm just going to briefly go over them with you. In order to address the opioid crisis, one thing that needs to happen is that we need to address overprescribing by doctors. So this has happened to some extent in recent years. Opioid prescription levels have declined since reaching their peak around a little bit after 2010, but doctors are still prescribing opioids at 3 times the level that they were prescribing them at in the early 2000s. So there's still more progress to be made there. There's some concern that reducing prescription opioids leads people towards heroin or other kinds of street opioids. The CDC, in its analysis of this issue, has found that the reduction and the benefits from reducing overprescribing outweigh the risk of, and the number of people that are switching over to other drugs. So the second area recommendation that we make is to narrow the gap, the treatment gap in the general population. Most people say that if they want to get treated for opioid use disorder, they're not doing it because it's too expensive or they lack health insurance. So expanding coverage and making sure that health insurance providers are providing low threshold access to opioid treatment. So that means not requiring people to be pre-authorized in order to access drug treatment programs. So this is a quote from the World Health Organization. The CDC and the National Institute of Drug Abuse agrees with this point, that the gold standard for opioid treatment is Medicaid-assisted therapy with medications such as methadone and buprenorphine, and these medications in conjunction with counseling and therapy are the best way to treat opioid use disorder. So in terms of the treatment gap in the criminal justice system, there's an incredible amount of work left to do here. We know that people that are incarcerated have drug use disorder rates that are 10 times the level of the general population. But if you look here, you can see the very low levels of treatment that people are receiving behind bars. These are nationwide estimates. So 1 in 4 people that are incarcerated are getting any kind of drug treatment behind bars. If you look at, in particular, at professional drug treatment, so excluding self-help programs and looking instead at medication-assisted therapy or professional counseling, it's under 1 in 5 people that are incarcerated are getting that kind of treatment. Connecticut is our leader about this, and you'll hear about the medication-assisted treatment programs that are occurring in the state. The federal prison system is very much behind in this respect and doesn't have an established medicated assisted treatment program within federal prisons. And that's a system that, DOJ, Jeff Sessions would be able to have, and the director of the Bureau of Prisons would be able to have great impact on ensuring that people that are incarcerated in the federal prison system would be able to access these forms of treatment. Okay, I'm going to try to wrap up quick now. 2 more recommendations. Reduce harms. So we're not going to prevent everyone from having a substance use disorder. We're not going to be able to get everyone access to treatment. It's just not going to happen. So we need to make sure that during a time that someone is struggling with opioid use disorder, we're minimizing their chance of dying. That means increasing access to naloxone, making it low cost, letting people know that they shouldn't use opioids with alcohol and other drugs that can be fatal, and increasing and creating supervised drug consumption sites so that people who are using can do so in a place where they would be able to receive treatment and be connected to treatments, be able to get connected to naloxone in case they overdose. This is something that Connecticut is a little bit lagging on. Cities like Seattle and San Francisco, New York City, Philadelphia is moving in this direction. As far as I know, Connecticut is not yet on the map in this area. Final recommendation, really end the drug war. Scale back arrests for all drugs, reduce prison sentences for all drugs to the extent that we're realizing that a public health approach is more appropriate for substance use disorder. What do we do about people that we brought through the system before we had this realization? One thing that we need to do is make sure that people that have criminal records are not barred from voting, that they have access to federal benefits such as cash assistance, food stamps, and federal student aid. I'll stop there. Thank you.
Yeah, I'll stay right here. Good afternoon or morning still? Morning. Good morning. I'm Colleen Gallagher with the Connecticut Department of Correction, Health and Addiction Services Division. I am here to talk mainly about a medication-assisted treatment programs that we've been building in the Department of Correction, but I would be remiss if I didn't talk about it in the context of the conference and the panel and how not only it came to be, but even though I'm here speaking on behalf of Dr. Maurer, it goes back before that. And I want to say a word. I want to say the word integration, which to me is about breaking silos. And when we speak about integrity and being an integral part of something, and we talk about integration, we bring parts together to a whole. And bringing in a program of this nature is very, very challenging, not just in the context of the environment that we're in, but for our individual approaches to treatment and care. And moving, it's a big paradigm shift, and it requires a lot of language changes, and it requires a tremendous amount of building of bridges. And I think that that is what has been the hallmark of bringing this into the Department of Correction here in Connecticut. As many of you here know, and if you don't know, being a combined jail and prison system has some unique opportunities and some unique challenges at the same time. And add on to that we also cover the parole division. Now you've got even more opportunities and or more challenges. But I think there's more opportunities than there are challenges, and I think that it's been very successful as a result. The bridges come from partnerships, and partnerships is the other big word I want to bring out here. Without the partnerships that we have with community providers and sister state agencies, again, these programs wouldn't be occurring today. We'd have to go back and look and perhaps the late 90s, when I wasn't even there, community providers knocking on the door of the Department of Correction, let us in, we want to treat these people, and over time, trying to find when that door can be open. There has to be a welcome mat, right? And so it takes time to get there. In addiction care and treatment, there's a saying about when the pain of being in it is greater than the pain of being out of it. And I think that for us, inside, being able to open that door for a new paradigm shift and bring in a medical model to supplement and support the current state at the time of addiction care was what was going to be the change that would work. So there are many things that I'd like to say, but I want to focus on these couple of points here. And it's not about numbers. There's a numbers and statistics session happening in another room, and numbers tell a story, and we have our researcher friends here, and we love our numbers, and I can give you some numbers too, but I don't think that bringing this in here is about numbers. It's about people, and it's about appropriate care, and it's about keeping up with the times, keeping up with the data, keeping up with what is evidence-based care. And evidence-based care shifts and changes over time, and you can't rely on 50-year-old data to get you through the next decade. So we have to keep up with that, and I'm really pleased to work for the administration that I work for right now that's willing to look at that and willing to work on paradigm shifts. But language is important. Language is a very important piece of this, and if we look at how our system internally was designed, we had addiction over here, and medical over here, and mental health back there, and custody and security issues over here. And not everybody talked to each other, not everybody worked with each other, and some days priorities ruled in one milieu versus another. But public safety and the security and the safety and security of our institutions, the people, the folks who are living inside and working inside, and the public is our priority. So how do you bring this conversation to the table and start to, instead of sitting at the table talking across to each other about what you're doing that's blocking me or what I'm doing that's blocking or risking you, to move from this banter across the table to begin to sit next to each other at the table and looking out in the same direction. And how do we go there together? And what we had in 2012 was a fabulous opportunity where folks began looking out in the same direction together. And champions were emerging as a result of that because people were hearing things differently. Our partners were coming to us and we were opening the door and listening differently. We have our administration that recognizing and understanding the dangers that we have statistics and numbers proving about people dying, within a week, a day, up to 2 weeks of when they leave. Something's going wrong here. And as an evidence-based model, medication-assisted treatment was going to always be the next eventual step. It was a matter of just when. It was when and how well we were going to do it. Dr. Maurer, as the Director of Health and Addiction Services, a primary care physician, occupational medicine certified, recognized and saw this as an issue, one that wasn't going away, one we needed to address, and went out and became certified in addiction medicine. And I think that's the piece that just shifts over and blends and expands the program from fabulous programs that we have across the state, from psychoeducation groups to long-term residential programs inside the Department of Correction, to bringing in this new medical model, which crosses over health, mental health, and addiction. And so to bring medicine in, we had to bring our community partners in, and we had to look at that. And how do we run a dual program with community providers, an internal addiction crew, physicians who aren't on site. There are many challenges, many hurdles to get through. But the priority had always been looking out from behind the table in the same direction. Somebody, I think you mentioned, where'd she go, Nazgol? You mentioned before about personal stories. And that is a real strong motivating force for folks when you know there's not too many degrees of separation between you and somebody who's suffering, either your family, a friend, a loved one, a death. Those conversations are happening more and more. You can't run, you can't hide from them. It's everywhere. And so the ability to sit together on the table instead of across from each other, that's what I'm saying. Like, this conversation just keeps moving and allows programs to grow. But there are rules, right? We didn't have the capacity to do this because public health law doesn't allow for that to happen. Well, our sisters in the Department of Public Health are very willing to work with that. Create some new language. Legislative language changes things. So, if there's something on your mind that you want to do, get it going. Move your bill forward. Move your legislation. Talk to people. That's how things happen. We just never stopped having the conversation. Never stopped having the conversation. And so there we get is the Department of Public Health supporting the legislative language that's going to change and allow for community health providers who are running methadone clinics in the community to actually open a licensed clinic inside the Department of Correction. How about that? Right, so we've got to get our partners. They were sitting there waiting at the door to come in, but they have to sit down and we have to talk with each other about how best to do that. So again, that was 2012. And here we are now in 2018. And what we had going on then was the protection of pregnant women who came in who may have been on a medication-assisted treatment, and that we would allow them to continue until their babies were born. And then that was the end of that. Well, today it's a new story. It's a whole new story. We have a few community providers that we work with. We have close to 1,000 people who have already been treated on medication-assisted treatment. Our New Haven and Bridgeport jails have been doing this for quite some time. And like I said, this isn't the numbers session. That's in the other room over there. This is the treatment session. This is the paradigm shift and the expansion and how we can get to where we need to go to. This is a Building Bridges conference, and I want to liken the development of the medication-assisted treatment programs to building the Chesapeake Bay Bridge. Does anyone know it? Nobody knows? Anybody know it? A 23-mile dual bridge that goes across the Chesapeake Bay. It's two ways. One side goes one way, the other side goes the other way. It's not just one bridge that everybody gets locked in. Some of it goes over the bay, some of it goes under the bay, right? So even just changing the way we look at that for a moment, if you will, if you've never been there, if you've never been on that bridge, give it a go. But part of it is a tunnel and part of it is a bridge. And that not everything has to look like you think it's going to look. When you say bridge and you look at the Chesapeake Bay Bridge, it looks like there's just a big gap. All of a sudden the bridge just disappears because the Navy ships and the container ships need to go back and forth across the water, and it's so they put the tunnel in those spots. But there's being able to open the door and look at the needs and how to get there together. And we couldn't do it without the support of the local wardens and their security teams, the community providers, the legislators, and of course our administration. Thank you, Commissioner Semple. Yeah, you got it. You're up. It was right there, so I couldn't miss that. So I know I'm out of time, but we are and have expanded addiction and medicine care to include medication-assisted treatment, and we are really happy about the Addiction Services Program and our community service providers working together to build these programs. And we welcome new partners as well.
Good morning, everyone. So in the interest of time, I'm just going to get going. Thank you so much. Nazgol pulls up these slides. My name is Emily Wang. I'm an internist, a researcher, a primary care provider, and unfortunately, I cannot pull myself away from these slides. And so this is kind of the boring part of our 15-minute presentation. I'm here with my partner, Amitha Smith, who will kind of really give, I think, the most important part of the work that we do. The narrative, the voice, the individual experience that really informs the work that we're doing within Transitions Clinic Network. One of the things that I think has been critical in thinking about the themes that are presented here and in this conference is this transformative, necessary paradigm shift, that in order for us to decarcerate, to think about a new vision of justice, that we need to reform and reimagine who ought to be at the table. And so one argument that I often make is I'm usually often the only physician in the room talking about criminal justice reform. For me, it's imperative that the health system be involved. And so this is the story and narrative I'm going to share. So, I've been doing this for now 12 years or so, and I've taken care of thousands of folks now who have returned home from prisons and jails. And there was a story that kind of stuck with me when I first started this work. So, a young kid, 20 years old or so, was in a motor vehicle accident, started taking prescription pain meds for, legitimate pain in his back, and slowly went down the slippery slope, started using heroin. Life got complicated and was arrested and incarcerated. And while incarcerated, like many, many adults in this country, first access the healthcare system behind bars. It's the only place where healthcare is constitutionally guaranteed aside from the emergency department. And so that's his first interaction with the healthcare system while he's behind bars. And so while he's behind bars, he actually does get diagnosed with diabetes for the first time, gets diagnosed with hepatitis C, gets to see a mental health provider. It's not great, but he does see a physician and a psychiatrist. Spends the better half of more than a decade and change inside. And when he came home, he'd never accessed the healthcare system, didn't know how to use it, had never held his own glucometer, never injected insulin. And so I first met him in the emergency department. He came home without scripts, without a primary care provider, and had actually overdosed. And to me, this is the place that, as a physician, that story drove me nuts. That we have a health system behind bars that almost no one knows about. You come home, and we can't help bridge that transition. And so a decade or plus ago, started thinking about how we can improve the health system for people, the millions of individuals that move in and out of the health system. In these two very siloed health systems, and started a program, Transitions Clinic, really informed by the voices of people with histories of incarceration, to change that script and that narrative. And so instead, you can see these are all patients' pictures taken from San Quentin and from our clinic. Instead of this patient that's first diagnosed in prison, this is a guy that has COPD and asthma, and is engaging with the health system inside. He comes home, and this is a picture of Juanita Alvarado. She's a person with a history of incarceration, a community health worker. That's his first contact with the health system. She meets him inside, says, look, when you come home, you're going to have a primary care doctor. You're going to have my telephone number. I'm going to help you navigate the social service system and the healthcare system. It's complicated. I'll be here with you. I've been incarcerated, and I know what it feels like to come home. Then you come to a primary care provider, and this is in clinic, and it's a safe space. We know you've been incarcerated. We can talk honestly about what it feels like to be incarcerated, what health risks you might have. We can get your medical records when you're in prison, when you're in jail, and figure out a plan where we can talk explicitly about how do we prevent you from going back in. We contend that that's probably the biggest health risk that any single individual has about going back in. Our patients do too, and so we can be real honest about that conversation. And then we connect you to the social service organizations that are working, that are functioning, that are vibrant in our communities, ones that work, some don't, ones that work, that do attend to your employment needs, to your health, to your housing needs, to your legal needs, to your family reunification needs. And so this is a picture, again, of our community health worker helping a patient try to figure out, with her food stamps, what kinds of foods should she buy to manage her diabetes. So we, with Transitions Clinic, wanted to shift that narrative. And fast forward, we have been able to expand now of 23 programs across the country, all based within community health systems that exist in the country, where we explicitly hire people with histories of incarceration to lead the work in transitioning and transforming the health systems that care for people with histories of incarceration. I'll point out that we have 3 programs in Connecticut and 1 that's coming in Hartford and in Waterbury. And so, like I said, this picture always kind of really just drives home this picture, is that we are training and hiring a new workforce to work in health systems. These are people with felony records that work in the health system, that work in Yale New Haven Hospital, that work in the health systems, and have to acknowledge the gross discrimination that exists within our employment structures, and also acknowledge the incredible experiences and skills that these individuals can bring to bear to make a better health system. We also embrace a real data-driven approach to the work that we do. And so this is some of the work that we've published. And, I just point out these things because this is what matters to health systems and to correctional systems. So we've shown in a randomized controlled trial that, programs like transitions, it reduces emergency department visits by about 50% over 12 months' time. And this was in a randomized controlled trial. And we've also shown that it reduces hospitalizations for preventable conditions if you're engaged in primary care like diabetes, hypertension, those things over the course of a year. We're showing, and these data are forthcoming soon, but that it'll reduce the length of stay, and these are data from Connecticut in jail, and also the number of parole violations, again, compared to a comparator group. And we know that direct referrals from correctional agencies, so when we have these partnerships that work, that is one of the only key things that needs to happen in order for us to reduce hospitalizations. So these partnerships, and we've partnered very closely with the Department of Corrections here in particular in Connecticut, are critical to the functioning of the health systems when people return home. In thinking about treating opioid use disorder, which is the kind of focus of this panel, so I think we're very much adhering to a really patient-centered approach to patients. And so what this starts with is screening all patients for opioid use disorder or risk of overdose. We do, where appropriate and where the patient is interested, start buprenorphine naloxone, start methadone or referrals to methadone, and even in some remote circumstances, start injection naltrexone. We treat, co-occurring mental illness, co-occurring infectious conditions right there in clinic. So a person doesn't have to go to all these different places. Right there in clinic, we'll start treating your hepatitis C. And I think these 2 last bullets are ones that I think are critical. So, I think in order to treat opioid use disorder, again, you have to think about the whole patient. And so in clinic, and with connections to other really high-functioning social service agencies, we attend to patients' concerns about employment, about housing, and their families. In particular for women, these are high stressors, and these stressors play a huge and I think often underplayed role in how we attend to treating opioid use disorder. And then lastly, we provide support through Amitha, through Jerry, through Manya, through our community health workers across the country, provide support for these community health workers in really tackling issues around substance use disorder. Substance use disorder, counseling, stigma, and medication adherence. And so these are our data looking at substance use following release. I will say that, across our network, and these are data from 700 plus patients, we've had no overdose deaths and only 11 emergency department visits for overdose. So, I'm going to turn to Amitha now to really give us a more kind of personal and patient-centered look at our substance use disorder and kind of what it feels like in her own experience.
Good morning, everyone. My name's Amitha Smith. Thank you, Dr. Wang. I must say, I didn't leap at the idea when she invited me to speak on this panel, but I just have to do my part. What I'm grateful to see now is a lot of resources to help people with
people like me that suffer from substance abuse issues. 18 years ago, when I was struggling with trying to maintain being clean and in and out of prison, there were a lot of resources to help me. So in and out of jail from like 1985 to 2000, just a repeated cycle, because there were no resources, there was no help. There was the methadone back then, being pregnant, bringing children into the world under the influence of heroin, struggling with that whole cycle, in and out of prison, in and out of prison. And what I do know is that prison is not a rehabilitation center. It's incarcerating a person because they have a drug problem is not the answer. In my own personal life, as I said, I used drugs for over 18 years, heroin, crack cocaine, and it was just a vicious cycle of not knowing what to do, bringing children into the world, and along with all of that, making terrible decisions, getting in terrible relationships, and then at some point, I was broken. And in February 25th, actually, just a few days ago, I celebrated 18 years clean. Thank you. And that's only that, and I appreciate the applause. And it's a life. Recovery is an ongoing cycle. It doesn't stop there. Every day that I get up, it's not a struggle, but there's different challenges in life. And because I got clean, doesn't mean life doesn't show up. Things still happen. Situations still arise. I just don't use no matter what. And I heard so many good things today about all the resources and the people that want to help people just like me. And I always say that this job that I have, doing the community advocate work, was tailor-made for me. I didn't have to get butterflies in my stomach when I filled out the application about, have you ever been incarcerated? Because that's a requirement. Do you have a history of drug use? That's a requirement. But it's really a privilege, because who better to help people that were in the situation that I was in than a person that has walked in their shoes. And it's my life's work. I've been clean 18 years. I've been doing this work for 18 years. And as I said, it doesn't stop. I just network with more people to try to stay connected, to help people just like me, because I know what it's like to be released from prison, not knowing where to go, not having anywhere to go, not having a whole lot of resources, and needing someone to take me by my hand and walk me and guide me and show me another way to live. So that's what I do today for the patients that we serve, the population that I serve, the people that I work with. I am the guide that I needed. I'm a hugger. They always say, oh, miss, you hug me too much. But I know they need a hug and afraid to ask for a hug. I knew what I needed, so I tried to give what I needed back then. And as I said, it's really a privilege to even sit here, because who would have ever thought? I always say, oh, crackhead, dope fiend like me, who would have ever thought? But there's a lot of stuff that I went through. It wasn't only for me. It's to help the people that I aid now. And I try to just share my experiences with them. It's like a two-part. I work in a detox center where I see it firsthand, and I know what it's like to lay in that bed, dope sick, and feeling like I'm it's the end of the world, and to also work with the people in the outpatient facilities that are released from prison, don't know where to go, don't know how to fill out a job application, don't know how to apply for DSS services and things like that. I'm that guide, and it's the most rewarding job next to being a mother. It's the most rewarding job that I can ever have. I told you I wouldn't have a whole 15 minutes to speak, but I just hope that, that my work can continue. I know that I can't change the world. I can't change people, but my desire is to make a difference in the world as we try to change it together. Thank you.
I'm just going to end with this, and I think it's important. I mean, I think nationally, states and localities are all really trying to think about what practical solutions do we have to think about addressing, if it's mass incarceration, if it's addressing right now the opioid epidemic. And to me, what's often missing in this conversation are the crucial voices, preferences, and values of individuals with substance use disorder in treatment decisions, in intervention development, in research, dissemination of the science of substance use treatment. To me, that's what's critical. I mean, if we're going to bridge the gap and really think about how we close the treatment gap, how we engage individuals into primary care, substance use treatment, whatever services, we have to have folks like Amitha, like the community health workers that I have the real privilege of working with, leading the way. In my, again, decade now plus, which is scary to say, of experience doing this, they look at someone like me and they're like, who the hell are you? Right? And then they look at someone like Amitha, and this is a woman that they can actually trust, and trust that she can lead them the right way, and that's how you build trust then in a health system that has, for the most part, I think, abandoned many of the patients that I've seen over time, and in a justice system that certainly has abandoned them over time. We are re-engaging individuals into systems that hopefully can function in the improvement of our whole community's health and well-being. So I just wanted to end with that. There are many people to thank, but this is a picture of our network, and really just a clap to my co-presenter, Amitha Smith. Thank you so much.
Hello, everyone. They didn't make the mic for me. Can everyone hear me? Pretty much. My name is Daryl McGraw. I'm the Director of the Office of Recovery and Community Affairs for the Department of Mental Health and Addiction Services. I get to say that today. My inmate number is 183422. I've given the Department of Corrections 10 years of my life. I have a lot of notes, but I don't know which ones I'm going to use, so bear with me. Because that's a tough act to follow, right? And if I can be a little off script, Dr. Wang is very hood. I can say that. Those of you that know her know what I mean, because I've had the opportunity to be on this role as a person with lived experience gives me an opportunity to sit in a lot of executive level meetings. And having that voice when they're deciding on what grants are to be used and where the money should go. I remember one day sitting in a meeting with Dr. Wang, and people were directing the money a certain way. They said, well, maybe we should target DUI. DUI? DUI, that's normally white males who have cars, who have jobs, who probably own houses, who are probably not going to reoffend. Right? There's also the opportunity, those men, I brought up at that particular meeting, we were talking about, well, what about young adults, 18 to 25? That's the buzzword. A lot of money is going towards those 18 to 25-year-olds. But I raised my hand in that meeting and said, what about the 26-year-old to 55-year-old male? The one that's forgotten about, the one that falls through the cracks, the guy that is expected to pull himself up by his bootstraps when he's released from prison. And the room was quiet. And through that one suggestion, the grant money went to a different population. And now the Ford Center is actually servicing adult males instead of the population that they were actually looking at in the initial conversation. I like to say I swung that conversation. There are many times that I have this opportunity to do so. Having the experience of seeing Michelle Alexander last night, I'm still, I celebrated, like you, in 18 years. Hopefully God will eventually allow me to see 18 years, but my clean date is May 7, 2007. That means I have not put a substance in my body, and I have not been in the back of a police car since that date. And today I get to stand here. Once again, this is my second year at the Building Bridges Conference. So what a gift, what an opportunity. But I feel that, I was always taught to those that much is given, much is required. So with that being said, there's so many different things. Like I know that my colleague Colleen said we're not going to talk about numbers, and I'm not a researcher by far, but there are some numbers that do trouble me, and I want to just bring them out. Well, not even trouble me, just to put some perspective. In 2007, it was mentioned that 369,000 people were incarcerated. I was one of them. I was one of those people in that 369,000. 10 years of my life in and out of prison on the installment plan. Now, there was another mention of a 28% decline in the Department of Correction, 28%. Guess what? I'm in the 28%. I haven't been back to prison. Well, I get to go back every once in a while, but they let me out at the end of the night. I wanted to talk to the commissioner and make sure I still could get that deal. But there is some numbers that I wanted to bring up, and I know we're going to talk about opioids, and I know I'm not going to get a lot of time, but I do want to talk about that 64% of the Connecticut's prison population is black and brown people. 64%. Those of you that know the numbers, we only make up 10% of Connecticut's population. I have to say that. I would be remiss if I did not say that. That even though there is a decline, we still make up a large population in those people. And those are sons, fathers, brothers, mothers that have no voice. They don't exist. They're not on those numbers. As Michelle Alexander explained, they're the invisible people. Demas, the Department of Mental Health and Addiction Services, has served over 112,000 people in 2016 plus. And we have one state hospital, and we work with 160 nonprofits and different things. And I'm very fortunate to work for the Department of Mental Health and Addiction Services. I know that there's a lot, and now I think that there is also, I wanted to make sure that I mentioned the fact that there are so many silos. Many of you work in different organizations and you say here, but that's your organization, this is mine. But slowly but surely we have been coming together, right? I remember sitting in a meeting and I introduced myself as a Demas representative, and it was DOC. They were like, oh, Demas finally came to the meeting? When 90% of those people that are incarcerated are going to come home seeking Demas services. So, of course, we are now definitely a part of that conversation. It is a struggle for me being a crackhead, right? A person that had smoked crack for many years, right? To sit in meetings and hear about how much money we are spending for the opioid crisis, and now it is a health issue. I cannot be an African-American male who has been through incarceration, suffered trauma, and grew up in the inner city and not say that. As a person of lived experience, I am here not only in a role to make sure that people are informed, but also I must speak truth. Because regardless of where I go, I must always speak the truth. So it is a struggle to see how much money is being swung towards, and now they're saying that, well, some people are saying the war on drugs is over. Then I say, well, release the prisoners of war. Release the prisoners of war. There are many people that are in communities that are ravaged, that have not come back from the war on drugs. And then as those of us know, we're starting to learn, and those that are reading and educated are learning that it's not a war, it wasn't a war on drugs at all. It was a war on poverty, a war on people. And then it was funny that it was mentioned yesterday that that would not be possible in the suburban community to actually wage a war on drugs with the population of people that are suffering. So with that being said, I'm glad that I'm part of the conversation, because now there is help coming to our communities. Did you see all those formerly incarcerated people, black and brown people with jobs that now, based on that, and people starting to listen and allowing and saying, you know what, they bring something to this table. I am now a homeowner. I am now a dad, right? I pay a lot of taxes, right? I remember in those days of 2 minutes. I remember the days of when I used to get an income tax check and used to be excited. Now I fear and cringe about income tax. And that's my birthday, if anybody wants to send a card. April 15th is my birthday. We are definitely, I just want to say there's so many different things. I have 2 minutes, and I just want to talk about just a couple more of the initiatives that Demas has done. I see a lot of partners in the room, and thank you, and we just need to work harder together, DOC, the Greater Hartford Harm Reduction, CCAR. CCAR has recovery coaches now in the emergency rooms, helping people right as they're going through their overdose process, being there for those families. And what a gift. Another conversation I was able to have when that initiative was started, I was saying that we cannot allow anyone to go in the role of a recovery coach if they didn't have lived experience. So it's important to have people like myself and many others a part of the conversation. I'm sure we're going to have many more questions, and I have plenty of data to talk about opioids or what have you, but we always must speak our truth first. Thank you.
All right. So am I still working with 10, 15 minutes?
10.
2? So, like, anybody who know me, right, you know where this is about to go, right? So, Lorenzo Jones, I'm the co-founder, co-executive director of the Qatar Center for Health, Equity, and Justice, we've got offices in New York, in Brooklyn, Albany, and Hartford, and Amsterdam. Still working that out. We have it, but we may not have it for long. So, I started out as an organizer in Asylum Hill neighborhood in Hartford, 1991. And so I've got a really solid history, at least my own version of that history, about how we kind of got here. So I've got a bunch of notes. I want to hit some points, because if I don't, Lewis and Kim will kill me. But let me just say these real quick, and I'm going to get into like a soliloquy. So the percentage of people of color entering the criminal justice system who have co-occurring disorders, we used to call that dual diagnosis, right? Chemical dependence and psychosis issues is like off the charts. Like, our folks being measured for that, obviously Demas and folks are on top of that, right? Or not, they're not on top of it. They get in their shit together, right? Judicial doesn't have like the infrastructure like to divert people and deal with that stuff. So there's like some real systemic problems like inside the system itself, right? Like, reentry doesn't start when people come home, right? Reentry, right? And this is something that Daryl and would bring into this table like in a very tangible way that we've never really seen in state agencies, right? That like reentry is pre-diversion, done well, done right. So it's like if you're doing diversion on the front end, you reduce the number of people. If you're identifying the issues people have on the front end, like pre-trial, pre-court, then you actually can put together a plan. Like for people coming home, you can reduce people's time inside. You actually can get they can access the healthcare benefits. If we could shut down prisons and not do that inside of prisons, that would be great. We'll come back to that. And the last thing I want to say about the points, right? And this is a saying from Lewis, I just got to say, I'm going to butcher it, but it's like we focus on the fruit and not the root in that sense. So focus on the root, not the fruit. The pre stuff, not the re stuff, right? Now let's go in here a little bit, right? Stop. Stop. State agencies like Demas and the Department of Corrections, providers are not the people who've helped create this change. They're the people who've benefited from it. Just stop, right? So when we went to the Department of Corrections in 1999, they told us to go fly a kite. The moment this switches in Connecticut, okay, is not when when Scott Semple becomes the acting commissioner, when Judge Norco becomes the community court guy, blah, blah, blah. No, it is not when Pat Hines and Department of Corrections start using healthcare dollars to pay for prison beds, and you couldn't get treatment on the ground in Hartford. You had to go to prison to get treatment. Give you the scenario. I want a bed. I need a bed. I'm ready for a bed. How you get me a bed in 2002? You get me drunk, you take me to the emergency room, and I threaten to kill myself. And they get us a psych bed. Because you couldn't get a bed for crack cocaine use. You couldn't get a bed for the other shit. So people who were trying to get people into legitimate treatment at a time when they wanted treatment had to get them drunk, go to the emergency room, and then threaten to commit suicide, which then skewed their entire record. Now the entire plan they're getting, right, is completely set up on math that's not done correctly. We can go back further than that. When cats were getting knocked in the 90s for cases, and they didn't even use. They would go and start using so they could get a plea bargain, they can get a diversion. So stop. Demas is not a hero. Corrections is not progressive. And I'll tell you, I'll give you one more to get me kicked out of here. Right? Go back. When we're doing the thing that changes in Connecticut, the moment it changes is when there's a fight at the community court. Most people don't even know about this fight. This is in like 1998, 1999 maybe. There's a fight. Now back up. I was the organizer who trained the Hartford organizers and organized in the state of Connecticut in the 90s to do disability rights. All the buses, they kneel now, right? I was trained to organize to do that. Like all the crack and powder cocaine, like whatever, community court. We organized in Hartford, the community court. The thing that allows people to accept the community court is that it specifically provides social services to people and as an alternative to like going into the system. So it was like in 1999, that was great because like technical violations were top, right? So what kind of cases could we move to the court that would reduce the number of people being pushed through GA-14 and into the system, right, around what was then called quality of life crimes. So that's when restorative justice was you big on the chain gang. Now restorative justice is like what we used to call justice reinvestment. We'll do that another day, right? It's like, so the community court has social services. Social services are like the carrot, right, and the stick. Eric Holder, Nancy Gist, they were all here. Judge Mint, we all met with Judge Mint's office. Everybody loved it, right? My man was, right? And it was a great thing. Judge Norco's there. It's all beautiful. And the court providing services. And as soon as the court gets up and running, all the people in Hartford are excited because we have this alternative to incarceration. Boom, boom, boom. It's working. It's got this racial component. But because of social services, people are getting the stuff they need, like at the moment of pre-sentencing, right? Pre-trial. So here's what happens. The mayor of Bloomfield, Faith McMahon at the time, who later becomes the state representative, and is the only and the first legislator that stood up for us for crack and powder cocaine. She was the first one. May she rest in peace. The mayor of Bloomfield came to us and said, I got a problem. She went to the court, to judicial, and said, I got a problem. People who went to prison in Hartford, Dutch Point, Bellevue Square, right? We all know them hoes, right? The people who went to prison at that time, right, when they, in the 90s, were beginning to come home from sentences. But the people who lived in Charter Oak, who lived in Dutch Point, Stowe Village, because those places were being de-densified, right? Because those families now lived in where? Bloomfield, Windsor, Glastonbury. So what happened? Folks were coming home from corrections when corrections didn't give a shit about like what you did when you got off the bus. They still don't. Right? When you get off the bus, right, and you had to walk over Coventry Street, beg, and be blackballed, what's happening was that people who used to live in Hartford now live in Bloomfield and Windsor, and those municipalities didn't have the resources to address those social service issues. So now she comes to the court, The mayor of Bloomfield goes to judicial and says, I want people from Bloomfield to go through the community court. Hartford folks lose it, and they say, wait a minute, this is our court. Now think about that, it's a bunch of black and brown folks. This is our court. That's how much the community court meant to people in Hartford because those services were real. That's how bad Bloomfield wanted them because they were so real, and the municipality didn't have the resources to provide them. Long story short, we lose that fight with Faith McMahon. They expand the court to include GA14's district, and Enfield, Bloomfield, Windsor, all these white folks from outside of like Hartford start like going through the court, but then all these deals start to happen, right? Oh, they don't gotta go to court. The prosecutor, and all these things get done. When we circle back, I'll stop here. Faith McMahon, as a result of that, when we go back in 2005, 2004, to demand crack and powder cocaine be equalized at 28.3. I saw Senator Ernie in here. Did he leave? I want to name him for a second when we're at the end here. We go back. Faith McMahon, because of that fight, understanding the difficulty of like what she was dealing with within the town of Bloomfield, and realistically look at the families who had moved from Hartford to Bloomfield, like ends up being the person who does the concept bill for crack and powder cocaine. And then she goes to a Christmas party and gets a bunch of people to sign on to it before they even realize what it is, right? And then she runs it, she moves it. Eventually other folks come on to it, but that moment is a turning point where we are able to build these urban, suburban alliances and collaborations and partnerships for policy reform through our organizing. And we did not depend on, at that time, Demas wasn't trying to touch this. DOC was still with their internal thing. DOC doesn't break until we break rail on the parole ban after Cheshire in 2007. Up until then Malloy comes in, and Malloy assumes leadership of this work. And I'll tell you this, and pushed out the people who had been doing it from 1999 and brought in a network of folks, primarily state staffers and program folks. And they did some great work, but guess what's about to happen right now? And I'll stop here. Malloy's out. And all the work that everybody's been bragging about, 13, 15 years of building bridges, all the work, all the success stories is a wrap. That's a preview of what you saw last year. The proposals for next year are already written, and they're gonna mirror Washington. And Malloy, who disbanded that network, left us in this position. And those of us, which ain't gonna change because Demas stuck to it, no, Demas gonna change when the doggone policy change. But we gonna change the fucking policy. That's it.
Thank you so much. Are the panelists okay to stay 5 more minutes for questions? We're running a little bit late, but if you're all willing to stay with us. So I think maybe what we can do in order to get a couple questions in our limited time is to, if folks have questions, please get behind the mics. Let's, if there's a couple questions, we can do a couple in a row and then respond to them, or if there's, let's just start with you, sir. Go ahead.
Let me address this Gallagher in the war on drugs. Let's redirect that war into the war on racism, because as Mr. Jones talked about paying attention to the root rather than the fruit is the byproduct of racism. Racism bankrupts every system it touches. And I can speak from personal experience because I am in recovery myself. I am recovering from the most debilitating condition known to humanity, and that is racism. I am a recovering racist. I've been a recovering racist for about 18 years now, and it has changed my life. Racism is the cause and effect. It is the reason why we have these numbers that you show. It's the reason why we're in this situation. Redirect the war on drugs or the war on black males to a war on racism, and we will get a lot farther when we do it together. Build those bridges that look like that Chesapeake Bay Bridge, that 23-mile bridge that goes underwater. Build those bridges. We I live in a state that is siloed and bifurcated. And the two biggest silos in this state are black and white. We need to focus our energy, be as intentional and deliberate as racism itself in order to stop it. If we don't, all those things that you're talking about and all those efforts that you're doing will have no effect on the root. The root is racism. Thank you.
Okay, I think we should take a couple questions or comments in a row, and then we can respond all at once, just so
Thanks,
we can
Mike
squeeze in
Askew
this.
from CCAR. I just have a question directed to Ms. Gallagher or Mr. McGraw. The Department of Corrections, if I believe this correctly, is entitled the Department of Corrections. How do two single state agencies work together to provide correction in the Department of Corrections to help those that, as we understand, have a high rate of substance use issues, to walk out there with some kind of assistance and treatment and understanding so that the correction is made when they walk out? That's it.
Okay, thank you.
Thank you. Thank you for that. There is not enough treatment available. So just to, first off the bat, to say how do we do what we do. We have programs available, services available, and partnerships available to do the best that we can to serve up services to people who need them so that we can help them as they move on. We require partnerships to do that because inside we can't do it alone. We bring in DEMIS, right? We bring in the Department of Social Services, and we continue to develop partnerships to expand those services. And if treatment was identified as a unique individual treatment and we had enough services and we continue to expand services so that individual treatment plans can be created, then we'd be a lot further along. But we don't have enough services, we don't have enough staff to create that much individualized treatment. We're on a trajectory right now to expand the service paradigm, the service continuum that we have. Everything from treating 18 to 25-year-olds, even though you voted against it, to changing the paradigm shift. So that's my part of this is expansion, the best that we can to help serve the needs that are there. From a DEMIS perspective?
I think that from a DEMIS perspective and a lived experience perspective, this correction that you speak of, that you question, is not going to happen until we bring people in with lived experiences, the experts. Yes. You need people that have actually been through this process and have been successful in transition before you can even talk to about actual true change. How can you tell someone how to go home and live off of $400 a week when they're used to X amount of dollars a week? One of the certain places where we fail in the department, in both departments in this system, if you will, is we don't even teach financial management. And you know, in our culture, money is not even spoken about. Like in the houses, I never knew how much my mother made. You know, that wasn't a conversation that we were having culturally. So then you expect people to be released from prison and know how to just magically budget their money, right? Magically be able to reintegrate back into society with skills that they haven't had. So what has to happen is those of us, myself, Mr. Jones, and many people that are in this state that do this work is not 9 to 5, this is 24/7. This is not just happens because we're on a panel. I speak like this every day, all day. I believe in saving lives, the gift of saving lives. This is what we do daily. So understanding that we need to collaborate more, but the one big issue it always boils down to is money. There's no way the experts that could do this work have to work other places because they're not being paid to go inside and deliver the services that will make individuals successful. So if we're going to be truthful and talk about what change needs to happen, then we need to start looking at redirecting funds to compensate those with lived experience who are the experts because they have transitioned and have become fathers and taxpayers and so on and so forth. They have, I mean, these people are the experts. We are experts in life change. So that's the way true correction is going to work, brother.
Okay, if you would like to ask one quick question, then that will wrap up.
Yeah, my name is Germano Kimbrough. I've been a long time advocate for people that have been oppressed. My father was actually a Black Panther member in the 60s, and I was by his side. And so I've heard a lot of great comments, and just, I guess Daryl kind of echoed my thoughts, of how do we get involved. And I guess I just really want to make a statement that, this can't happen without us. There's a mantra that says nothing about us without us, and that we all bring something to the table. I am very cautious. I was a part of the harm reduction movement back in the 90s. I helped form the Connecticut Coalition of Harm Reduction. We did decriminalization of marijuana, expansion of methadone and needle exchanges, where, like Daryl said, this stuff had to be done underground 24/7. And I'm just really trying to be a part of the solution. I'm formerly incarcerated. I finally got some education, got a clean record, helped other people get records. And, it's tough. And it is, it's hard to talk about these things without including, race, power, and privilege, right? And how do we become emasculated or, non-threatening, especially as Black men before we're received and heard at a table, right? And so for those of you that are in the room and it's uncomfortable to hear this stuff, it's just as uncomfortable for us to tell our stories, right? And so what we learned as advocates and people with lived experiences that, we have to do self-care. We have to breathe. Sometimes, we didn't breathe. And I was one of those persons that crashed and burned after 15 years clean and doing a lot of work. When I relapsed after a car accident on pain meds, there was nobody there. Who does Superman call when he runs into kryptonite, right? And it's been tough. It's been a tough road to recovery, And, Lorenzo, I appreciate your advocacy. Many Black men can't stand up and make those kind of comments and then still get a job. It's tough for me because I've been an advocate of the people for a long time, so I got to drive Uber. I had jobs that should have been no-look layups. And, I'm struggling, right? Do I go back to the block, because I'm trying to make a living? But, I do want to be a part of this movement, this advocacy that's, it's in my heart. I'm at my best when I'm working with people. And, I just encourage people to, like Daryl said, to incorporate, those people with lived experience. I'm a certified peer support specialist. We share our stories and give people permission to heal through our stories. And so I just want to put that into the conversation.
Yes, Lorenzo. Thank you.
I thank you for that. First of all, the name Kimbrough is the name Kimbrough. We know what that. Right, that's right. But I wanted to say something because there's a couple of people in the room who had very important conversations with us when we were doing the advocacy. Senator Newton here, right? People should understand, when the crack and powder cocaine bill, the initial bill that equalized at 2828, when that bill passed the House, it kind of got bogged down and fell into the crap of the Capitol to go to the Senate. We eventually get it moved. 2 conversations I had with us in the same night. The first one is with Bill Dyson has it with us, Legislator Dyson. He comes to us and he says to us, 1 o'clock in the morning at the state capitol, 1:30, me and our team, he says, listen, y'all, what you're trying to do here is very similar to this frontier settlement kind of relationship, right? And there's a settlement that's the legislature, that's the status quo, and then there is, this frontier where things clash, right? And you all are living in this frontier area attempting to change this settlement to grow it, right? And he's talking about the advocacy, he's talking about the organizing, he's talking about the base of people on the ground who he knows as a legislator have not been in part of this conversation. And he's pretty much giving us the good try, better luck next year speech. Legitimately so, because it's 2 hours later, we're sitting there, so a bunch of other stuff happens, and Senator Newton walks, I'll never forget him walking down the stairs at 3 o'clock in the morning with the crack and powder cocaine bill in his hand. and he walked it himself up into the Senate and the caucus and demanded that it move. I don't know, I was in the back room, I'm sure that's some glorious story, whatever, right? But what we do know is that he talked to us, and then he walked away, and when he came back, they were calling our bill, right? So I just want to say that to the point around advocacy, like when we first started doing this stuff, the NAACP wouldn't stand with us. White progressives wouldn't stand with us, right? Nobody would touch us. We were like political lepers. Like some of the guys, I'll stop. Well, my point is, and I'll stop here, is like we have a saying, and when we do this work, and I do this training and tell people, we do the work that keeps us up at night, not the work that helps us sleep better. Right? So like right? Last point to that, like just an organizing tip, an advocacy tip, a base building tip for people outside the outside game, outside the legislature, right? If you are trying to change the VA, you organize veterans, right? But you have a problem because all of your organizing and advocacy efforts are competing with their doctor's appointments, whatever trauma, what other issues they're dealing with. If you want to change the VA, you organize caregivers of veterans, okay? You want to pass medical marijuana, you organize caregivers of patients. If you want to organize formerly incarcerated people, organize our caregivers. Who's the caregiver of formerly incarcerated people? Right? That's important because, I promise I'll stop here. That's important. It's an organizing rule we learned because the pool of people who are formerly incarcerated, criminal justice involved, is too small, right? And it's constantly being diluted by like voter, different statutes, hospital appointments, doctor's appointments, PO appointments, job appointments, ain't got enough time off for work to go to the Capitol. No. Right? The people who are going to carry this to the next stage are the caregivers of people who are formerly incarcerated. And last thing, FIP is code. Formerly incarcerated person is code for Black male leadership. So if you are primarily going to only organize formerly incarcerated people, you are saying to people in a codified way, I'm only going to work with Black men who are criminal justice involved. You can't do that. You're not going to build a broad enough base. To Daryl's point, you're not going to build a broad enough base. You're not going to build any power, and you're never going to have the power to move the legislature. Organize the caregivers, neighbors, employers, librarians, midget football coaches, parents, co-workers, congregants, fellowships, folks, of formerly incarcerated people. And let formerly incarcerated people deal with their life.
Thank you to the panel, and thank you all for participating.